Okay, let's get started. Hello, my name is Greg Nunabel, communications consultant with SSM Health. Really glad to join the Community Council and various organizations that they partner with to tell you a little bit about the excellent behavioral health services that we have in the St. Charles community and beyond. Very pleased to be joined by one of my work colleagues, Lisa Wenger. She is manager of behavioral health out here in St. Charles County, and she is here to speak with us specifically about substance use disorders and some of the effective treatments for that, how to tell if somebody is ready or not ready for treatment, some of the behaviors to expect from somebody who is struggling with that, the types of treatment that we offer and that are available for these folks, and how you can be supportive of a loved one's recovery. So with that, I will turn the floor over to Lisa.
All right, thanks, Greg. Yeah, so a little bit of my background. I have been working as a licensed professional counselor since 2007. I've worked with anyone from small kids in foster care to adolescents at risk for homelessness or homeless. I've worked in substance use with adults. And now I am with SSM, managing several programs, anywhere from severe mental health issues to brief needs, to our long-acting injectable clinic that works with people with psychosis and substance use issues. And we also have a substance use IOP program. So I've kind of been all over the place. My love is for helping patients, and right now really supporting those who are doing the work with the patients and having robust programs that are best practices, just to keep moving progress along. So that's a little bit about me. We're going to talk today about addressing the substance use crisis that we have going on right now. We're going to go at it from a couple of different angles. So the theme of today is going to be, while people present with substance use issues at all stages of life, oftentimes the root of the issue stems from something that's not easily identified. Understanding potential sources of the issue, the nature of the issue, and various treatment modalities can equip us to better meet the needs of our patients or loved ones by increasing our understanding, empathy, and treatment. So we're going to look at different age factors that are coming into play, especially in the last few years, what data has shown us, the science behind substance use, interventions, and then treatments. So first, we're going to start with our adolescents. We're going to look at adolescents and then older adults primarily when we talk about age factors, because that is when we hit adolescence, that's kind of the beginning of when substance use becomes an issue. And what we're seeing now trending is pretty scary when we look at our older adult population. So with adolescents, typical reasons why adolescents begin using, they use it to fit in with their peer group. They use it to feel good. So this is a little different than feeling better. So to feel good is just that euphoric feeling that comes with substance use. To feel better is alluding to adolescents who are struggling with either mental health concerns or depression or anxiety, or really looking into if they've experienced any trauma, abuse, or neglect in the home. Bullying at school, a lot of that plays into feeling better. To do better. So we do see trends with adolescents of wanting to perform better at sports or with their education. And so they're using stimulants to get to where they feel like they need to be. And then, of course, experimentation. We all know adolescents love to experiment and they have those risk-taking behaviors. So that really plays into why they're starting to use substance. So in 2018, high school students in their senior year of high school, 58.5% reported to have consumed alcohol already, and 47% reported using illicit drugs. So to me, those are a little bit more staggering than what I feel was going on when I was in high school. So we're going to look at risk factors for adolescents. Part of the reason we want to know what the risk factors are, because when we're working with substance use, we really need to go back and do what we can to heal or address the reasons for use. So when we look at risk factors and we look at treatment later on, we'll come back and circle back around to what these risk factors might have been. So stressful early life experiences, anything from discord within the family, if children go through their parents divorcing, loss of a caregiver or family or grandparent, anything like that that causes stress early in life can put a person more at risk for use, not only in adolescence, but later on. History of physical and or sexual abuse. So when we talked on the previous slide about needing to feel better, that's really getting at this. So if they're dealing with something they don't know how to process or they don't know how to share, especially if it's something that's ongoing and hidden, they can use substances to either escape those feelings or to feel better from those feelings. Predisposition, so genetic vulnerability. If substance use is part of their family history, then they can have a genetic vulnerability. So just experimenting once or twice can trigger a much bigger issue. Prenatal exposure to alcohol or other drugs really gets written into the genetic code and DNA of that child. So if it's in the system when they're developing in the womb, then they're going to be more prone to abuse later on or misuse of drugs. Lack of parental support and monitoring. This one seems a little bit evident, but if parents don't know what their kids are going to do, they're going to try to get away with what they can. And we'll talk later about early intervention and what that looks like with parental supervision and monitoring. Association with drug using peers. Of course, this gets back to the previous slide of wanting to fit in and have that support from their peers or that acceptance from their peers. Other mental health problems such as mood, anxiety, learning, or behavioral disorders. Any of this can get into that wanting to feel better or wanting to perform better. So implications for adolescents. When we're talking about substance use, we really want to understand what it's doing to the adolescent and specifically what it's doing to their brain. So the brain is still maturing in significant ways into adolescent years. Before age 11, a lot of what brain development is doing at that time is developing and creating new pathways and really growing as many connections as possible. Around age 11 or 12, the brain starts pruning. So it's essentially just like pruning a rose bush or something. You're cutting off the places that are not used enough or not active enough. So pruning, the reason the brain does this is it allows for more efficient information processing. If the brain has 15 pathways they can choose when they're making a decision, it could be a little overwhelming. But if they can prune down to 5 that are really effective and efficient and important for that individual, the information processing goes a lot quicker. So pruning takes away some of the options the brain has that are no longer needed or no longer effective. We know that healthy brains are able to develop longer chains of nerve cells. So longer chains of nerve cells allow for more complex decision-making in adulthood. So if we are having damage done to the brain when the brain's really working to develop these longer chains, that individual might have issues making more complex decisions later on in life. So pruning happens back to front. So it starts in the back of the brain down at the brain stem where it connects to the spine in the limbic system, and it moves towards the front of the brain right in our foreheads where the prefrontal cortex is. So depending on when substance use or misuse is occurring with adolescents, it can damage different parts of the brain or hinder different parts of the brain, depending on where their brain is in that pruning process. Substance use can have a major effect on brain development and make someone more susceptible to developing substance use disorder later in life. So why this is important is when we're talking about lifetime of substance use, while that might just be experimenting in high school, it's setting the brain up for issues with developing into something more severe later on in life. So maybe I experiment a little bit in high school, but then when I get to my 20s or 30s and I have a major life stressor and I turn to substances to handle that, it might slip into a substance use disorder a little quicker or more easy for me. So now we're going to switch and talk about older adults and what's going on with that population. So in 2010, more than 1 million older adults had a substance use disorder. And by the end of 2020, we were expected to have roughly 5.7 million older adults experiencing a substance use disorder. So that's looking at well over 4 million adults in just a 10-year time frame that will struggle with a substance use disorder. The research suggests that substance use disorder is an emerging public health issue among the nation's older adults. So on the graph on the side, by far, alcohol is the most abused substance with our older generations. So the urgency for understanding this, the baby boomer generation, those born between 1946 and 1964, are really what we're looking at here. So by 2030, we're expected to have 72.1 million baby boomers. And with our current stat of 5.7 million older adults experiencing substance use issues, that number will trending is continuing to grow unless we do something, some interventions with that population. So by that point, we're looking at a much larger group of people that can be affected by that. The 1960s and 70s led to changing perspectives on substance use and acceptability, and it's really looking like some of those changes in perspectives could be what's contributing to their use right now. So we'll talk about this a little bit more later too, but society as a whole has some incorrect assumptions about substances in older adults. So it's not being caught or screened for as much as it's needed. Older adults are less likely to be screened and assessed. And something we'll look at a little bit later too are symptom confusion and then the inappropriate DSM criteria for older adults. So when we go through what some of the signs and symptoms are, we'll talk through that a little bit more. So we're going to talk through the risk factors for our older adult population. When we're talking about sex, males are more likely to gravitate towards alcohol or abuse alcohol, and females are more likely to abuse prescription medication. Caucasian ethnicity seems to be the one that's most affected right now. Those suffering with chronic pain or physical disabilities that reduce mobility are more at risk. Transitions in care or living situations are one of the things that are being identified. Poor health or chronic physical illness can lead to depression, feelings of hopelessness or helplessness, all contributing to the need to use substances to help handle those emotions and losses. And then significant drug burden or polypharmacy. So the more drugs you're giving someone, the more comfortable they are with taking some of those or using substances to alter their mood or handle their ailments. So risk factors that are psychiatric and social with our older population, avoidance coping. So one thing we also know when we're talking about mental health is that there has been a huge stigma for a long time about receiving mental health support, especially with males. So they don't always have appropriate coping skills. So a lot of avoidance coping with substances is a pretty readily go-to way to handle issues that we are trying to avoid. So if there is a history of substance use disorder previous in their life or alcohol misuse, so when we talked about adolescents that might use or experiment in high school, what that might look like later on in their lives, same things with our older population. So if they have a history of it earlier in their life, they're more likely to have that resurge when they hit their older years. Previous concurrent psychiatric illness. So co-occurring disorders is something that's pretty common. Not more often than not, I would say that somebody who is struggling with a substance use disorder probably has a concurring psychiatric illness, whether depression or anxiety or something more severe, schizophrenia or bipolar. So it's the same with our older population. Affluence tends to be a risk factor. Bereavement. So going back to the avoidance coping, not really wanting to or knowing how to address the emotions that might be going on. Unexpected or forced retirement. Boredom. That's where this comes in. And then social isolation, which we're going to pick up on again in another minute. So social isolation, if they have lost their significant other, or if the children are all out of the house with their own families and not checking in on parents as much. We hear a lot in one of the programs I supervise about feeling like a burden to their adult children or friends. So they tend to isolate and just try to deal with the problem instead of reaching out when they need support or a little social interaction. So I figured any presentation in 2021 is not really going to be a complete presentation without talking about how COVID and the pandemic has affected things. And the data we have with being still less than a year into this thing is pretty alarming. I was pretty shocked when I started doing some research into this. I know just from the work I do that it's picked up quite a bit, but to see this in numbers and data that we actually have was quite alarming. So right now we have 4 out of 10 adults reporting symptoms of anxiety and depression. This is up from 1 to 10 adults just in 2019, so a little over a year ago. 12% of the population report an increase in substance use since the beginning of the pandemic. So in 1 year, substance use has increased 12%. Populations most at risk for using substances right now to cope, young adults. We're getting lots and lots of referrals from people late in high school years or early college that are really struggling with the social isolation and attending school or college online and not having that peer support and contact like they used to. People experiencing job loss are really, so that's always been a risk factor, but with the way industries are going right now, this is taking a huge toll. Parents with children in the home is a category that are turning to substance use to cope and manage the stress or the anxiety or the lack of support. Communities of color are really being affected right now, and then essential workers for a variety of reasons, anywhere from fear to anger to social isolation to feeling like outcasts from the society because they might be contagious. A lot of different reasons that play into our essential workers. 20% of people in the last year have reported needing but not receiving mental health services. So that's pretty alarming. What we're seeing right now, I think, is such a huge uptick in inpatient behavioral health admissions and also in our outpatient programs because these people have needed the help but have not felt comfortable reaching out for it. And we'll talk through what some of that might look like in a minute too. So now we have people coming in that are sicker and more acute, needing the services and support, not just with mental health, but substance use as well. So barriers that we're seeing during the pandemic. So lack of services is a major one. Several hospitals, probably more than not, have had to restrict some of their other services, whether it's because it's not considered an essential service and they needed to limit the exposure and transmission rates, or because they needed to make room and allocate resources for COVID care. So we have the lack of resources or the lack of services. A lot of behavioral health and mental health substance use programs have tried to do a virtual component to that, but that is not something that's also readily available to everyone. Lack of social support. So just with shelter in place orders and social distancing, a lot of that, the lack of social support. We're going to talk in a little bit about how important social support is for substance use recovery. So lack of social support is something that's really causing a hindrance for people to receive treatment and heal right now. Loneliness and isolation. We are social beings. So when we are restricted in our ability to connect with loved ones and receive that feedback, it's one of those things like when we talked about the youth about trying to feel better. Substances can help numb those feelings or distract us from those feelings. Lack of insurance or lack of in-network options. So when we talk about the increase in job loss, that also comes with lack of insurance. So while the substance use is increasing, we also have increasing barriers as well. So implications for the pandemic and where this is going to lead us down the road. So historically, when we've had pandemics or times when we've had to adjust our social and cultural interactions, psychological distress can last up to 3 years after an outbreak. So assuming that we are able to return to a quote unquote normal state of functioning in 2021, we can still be seeing psychological repercussions of this into 2024, 2025. Financial distress adds significant implications to mortality due to deaths of despair. So not being able to properly care for themselves or going into deep depression due to financial distress. And as we know, with industry shutting down and with lack of jobs, our financial distress right now is fairly high compared to what it's been. So additional deaths due to suicide, alcohol, or drug misuse may occur until 2029. So we're in this recovery process for at least a decade. So all of the increase in substance use we're seeing now, just because the pandemic ends at some point or we return to normal functioning at some point does not mean that the damage that's done during that time is just going to disappear as well. So I want to talk through a little bit of the components of substance use or abuse and what addiction looks like. So addiction occurs when repeated use of drugs changes how a person's brain functions over time. I think sometimes we tend to get in a mindset of it's just a habit or it's just easier, and we forget how hardwired this becomes for people struggling with substance use. The transition from voluntary to compulsive drug use reflects the changes in the brain's natural inhibition and reward centers that keep a person from exerting control over the impulse to use drugs, even when there are negative consequences. So the brain kicks into overdrive. The brain gets set on autopilot, and it becomes less and less of a choice of that patient or that person, and becomes more of an automatic need or drive. So here's a quote. One of the most challenging aspects of addiction is that it is a progressive disease. Early warning signs can be hard to spot, and unhealthy behaviors can develop into full-blown substance use disorder, often called substance abuse, if not addressed. If you know your loved one's interests and habits, the early warning signs of trouble will be more apparent because you will sense when something seems off or amiss. So in a little while, we're going to talk through the brain and the science behind addiction. So remember this quote when we get there, that it's a progressive disease. It gets harder to treat the longer it goes on. So the early intervention and warning signs are a must, really, to have successful treatment for substance use. So early warning signs. In 2018, 21.2 million people aged 12 and over needed substance use treatment. That's about 1 in 13 people. So when we break it down into categories, 1 in 26 adolescents. So that's about 1 child in every classroom. 1 in 7 young adults, which is probably, depending on the college or classroom they're in, it is anywhere between 2 and up to 10 people in a college classroom. 1 in 14 adults aged 26 or over or older. So that's really, we tend to not realize that we tend to think adolescents and college kids are the ones with the problems, but really this is suggesting the young adults do have a need, but even more than adolescents, we have our middle-aged and older populations that are needing help too. So while they need the help, only about 3.7 million people actually received help. So we're missing out on about 18 million people who need the help, but are not either ready or willing to get the help.
I have a question just along those lines. You talked about how this is a progressive disease. It's harder to treat the longer it goes on. But then we've seen a significant uptick in these instances over the course of this pandemic. I'm just curious about what you're seeing in our clinics with SSM Health Behavioral Health. Are we seeing more people kind of come into the realization that they're having this issues, or have they been magnified as a result? And are they getting to the point of seeking help?
I think we're still pretty early in that. We're getting a lot of people who have said this started in the last 6 months, or this started with the pandemic, or the stress of my job because of this, or lack of job. So we're seeing a lot of people who are attributing the pandemic to their need for treatment. I think that the picture that we need to see that we're missing right now are those that are not reaching out. So we don't have that data because they're not reaching out, and we're not able to speak with them. But there are quite a few people that are reaching out for both the clinics and our IOP programs that are attributing the pandemic. So those that we can say could potentially be early warning signs. They're reaching out early in their disease, but until we really know that patient's full history to know how long have substances really been used. Right now, they might be used even more, but we might not know how early we're able to intervene until we know their full history with that. So better success with early intervention decreases the brain's reliability on substance use pathways, which we'll talk about a little bit later too. And early intervention can help people more quickly recover. They can develop and retain positive relationships, gain access to employment, and ultimately lead more fulfilling and meaningful, productive lives. So early intervention is the key. It's also one of the hardest parts, and it's then convincing someone that they need help when it hasn't completely destroyed their life is another barrier. So when we talk about early intervention, people can benefit from drug abuse intervention even if they're not addicted. When we wait till somebody's already addicted, it's adding a whole nother component in there. But if we can get them when they're still in the misuse stage, it tends to be a lot more successful. Substance use disorder treatment should be tailored to the unique needs of the adolescent or the patient. We cannot do a cookie cutter approach to this. We really need to tailor it to a lot of the things we talked about earlier about what are the things that lead to substance use. Is it a genetic vulnerability? Do they have trauma that we need to work on as well? Is it a issue of not feeling like they're accepted with their peers? When we can look at those needs, a lot of times the substance use is just the result of some of the other things they've experienced in their lives. So when you take away the cause, the symptom tends to diminish a little bit as well. Treatment should address the needs of the whole person rather than just focusing on the drug use. A little bit of what we just talked about. Behavioral therapies are effective. So we'll talk through behavioral therapies, and we're also going to talk about medication therapies. And then the support role. So us as either the provider or the caregiver or the loved one, we really need to work to be supportive and encouraging while providing needed structure and supervision. So the key to working with someone or supporting someone who's dealing with substance use is understanding what they're going through, understanding that the struggle with them is very real, whether it looks like they're really engaging in it or not, and that they need our love and support, but they also need us to have strong boundaries. So some of the behavioral signs, before we get into how we're going to treat it, let's talk about what we're looking for. So these that can apply to all age groups. Frequent tardiness to school, work, or extracurricular activities, family activities, churches, holidays, things like that. Sudden poor performance at work or school, loss of interest in activities or hobbies, neglect or damage to relationships with friends, family, or peers, teachers or coworkers, significant changes in peer group. And we tend to think of that with adolescents, but it's also pretty important to note in adults as well. Mood swings or angry outbursts, physical or verbal aggression, secretive or defensive attitudes about belongings or personal spaces. So not wanting you to see what's on their phone screen, or not looking through their bag or pockets, things like that, going through glove boxes in cars, secretive and or defensive attitudes about activities. Why do you need to know that why I was there? Or, I was just late. The traffic was bad. That there's nothing else. Things like that. Changes in eating or sleeping habits, losing money frequently. So with adolescents, giving them money for an activity or whatever, and then them telling you that they lost it, or adults too, that pulling money out of the ATM or whatever, and it doesn't, you're not seeing the result of where that's going. Money or valuables missing from the home, dishonesty or stealing, and then extreme irritability, hyperactivity, or talkativeness. So there's some physical signs: rapid changes in weight, inability to sleep, explained bruises or marks, especially when you're dealing with intravenous drug use. It'll be inner arms, legs, bottom of the feet, or between toes. Pupils contracted or expanded, blank stare or spacing out, eyes that are bloodshot, running nose or excessively watering eyes or excessive sweating, unexplained nausea, vomiting, or nosebleeds, cold or sweaty palms or shaking hands, a puffy face, excessive paleness or flushed cheeks, slow staggering walk, low or no energy, and overall deterioration of personal hygiene or appearance. Some of those are ones that are a little later than what we want to intervene, but intervention at any point is important. So one of the things we talked about earlier when we were talking about our older adult population is that it's frequently confused with something else, or that the DSM is not appropriate for diagnosing in older adults. So as we're talking through some of these, take note to see what else you might think this might connect to, what other issues it might be. So falls, bruises, or burns, poor hygiene, headaches, incontinence, increased tolerance to alcohol or medications, unusual response to a medication. I think that's one that we typically miss quite often. Poor nutrition, idiopathic seizures, dizziness, sensory deficits, blackouts, chronic pain, disorientation, memory loss, recent difficulties in decision-making, overall cognitive impairment, sleep disturbances, problems, or insomnia, anxiety or depression, excessive mood swings, family problems, legal problems, social isolation, running out of medication early, or borrowing medication from others. So when I was looking through this list, a lot of this reminded me of early warning signs of when my grandma was developing dementia. And I have these, and some of this really connected with what I'm seeing them go through just with getting older. And my dad has quite a few heart conditions. So a lot of this is playing into what I'm seeing with him too. So it's very easy for me to see why some of this can be missed, especially with our older adults. So when we're screening, whether it's any age range, we need to start with facts and questions. The more we put somebody in a defensive position, or the more they feel like they have to explain themselves, the less likely we are to get honest answers. So start with questions and facts. Do it from a completely non-judgmental standpoint, just wanting to get a clear picture. And then brief assessments can lead to assessing the overall level of risk. And the longer the assessment gets into, the less likely they are to be honest or continue to engage. So when we're talking about assessment for adolescents, some of the assessments we have out there that are really good at getting a lot of information pretty quickly and helping us understand where they are. So we have the CRAFT screener, which really goes through questions relate. So the abbreviations for, or the acronym for it, is a little interesting, but these are the things that we need to look at. Have they ever ridden in a car with someone who's been under the influence or intoxicated? How do they relax? What do they do when they're alone? Have they been more forgetful? Have their friend group changed? And what kind of trouble have they been getting into? Is that pretty typical? So it's 6 questions designed to assess high-risk alcohol or other drug use disorders. The brief screener tool for tobacco, alcohol, and drugs is 1 question per substance. So you're not, those who tend to be a little bit more private or protective of their use, they're not going to be triggered if you go into too many questions. And then the screening to brief intervention screener. This will provide information on the patient's risk level. So high risk, low risk, medium risk for developing a substance use disorder. So when we're assessing older adults, here's a little bit of information about why this tends to be so tricky. Part of it are the symptoms that we just talked about that can look like other things, but this is also typically assessed by a primary care provider. We don't have, with adolescents, we have teachers and counselors and parents and coaches and a whole bunch of other people who have eyes on them. But with our older adults, we don't have as many people who are paying attention. So there tends to be hesitancy due to stigma and discomfort of holding somebody accountable or accusing somebody of maybe having substance use issues, and when you could potentially be wrong. Our primary care providers have increasing demands and decreasing time, so they're not able to spend as much time with their patients, so they're not appropriately assessing as all the time as might be necessary. So here's the question that we just talked through was, is this a normal aging process or is this a substance use issue? So to properly address the emerging data that we see and the trends, we need to err on the side of it could be a substance use issue, but then we come back to that stigma and discomfort of calling someone out on it. And so primary care providers are also wanting to be a little bit more supportive and not as confrontational. I think this also comes into adult children with parents too, that it's a little bit harder when you have to get into a little bit more of an adult or peer role with parents or loved ones. But assessments that we can use for older adults. So we have the CAGE aid, which is a lot like the CRAFT for adolescents. Have they tried to cut down and they can't? Do they seem easily annoyed? Do you see any guilt in them? And what are some eye-opening moments that triggered you to think that there might be something going on? Then the Michigan alcohol screening test, the geriatric version is appropriate. A lot of hospitals use the audit C, so the alcohol use disorders identification test, or the alcohol, smoking, and substance involvement screening test. So what does intervention look like? For us to effectively intervene, we need to have realistic expectations of what recovery looks like. It is a lifelong issue. And when we talk through the science behind this in the next slide, we'll get into that a little bit more. But relapse is a part of recovery. It's there, and it's not there with just substance use, which we'll talk about too. Lying and deception are part of the disease. Shame and guilt are very real. And when we dismiss those, we're dismissing a big part of what the person's going through and what support they need. Boundaries are an absolute must. When we set boundaries appropriately, we don't do it to shame or discipline or punish. We do it as a way to say, it is in your best interest that I maintain my boundaries or that I set boundaries for you. And so when we can approach that from a loving standpoint, the boundaries can be very effective and well received. What is our role as either a caregiver or a provider? We really need to be supportive. We need to go into every interaction assuming that the person had the best intentions, and we're committed to their recovery. We cannot go in emotional or take anything that they're doing as a personal attack or a personal endeavor. We need to set clear expectations about how we want to be there to support what be with. And we need to be willing to give second and third and fourth chances, as many as they need, because relapse is very much a part of recovery. And then we also need to understand the science. We need to understand what that person's going through, not just from a psychological standpoint, but from a very physical standpoint. So the science. Some characteristics of addiction are very similar to other chronic diseases. So I read a statistic that 40 to 60%, when we talk through relapse, 40 to 60% of people who are going through recovery have relapses. And that is no different than when you're looking at somebody who has asthma or diabetes or heart problems, that they have to stay very much invested in their health. And so somebody who is diabetic might have those times where they indulge in a lot of sweets. So relapse happens with other diseases besides just substance use, but we tend to stigmatize it a little bit more with substance use than we do with other health conditions. Addiction changes the brain and impairs the way it works. When we can understand that, we understand we're not dealing with the same person who we were dealing with before they started using substances, that their brain is physically different. It is preventable, it is treatable, it changes the biology, and if untreated, it can last a lifetime. It typically does not go away on its own. Substances have a way to trick the brain's reward system. And this is incredibly important because it's one of our driving factors of why we do what we do. Our brain is designed we want to ring that reward center bell as much as possible. That's how we find fulfillment in life. That's how we get positive reinforcement for our behaviors. So when you have a substance that's tricking that reward system, you're really messing with what our natural abilities and drivers are. So substances causes higher than normal releases of dopamine. And when our brain gets flooded with dopamine, it adjusts to those increases, and then drugs become less rewarding and cravings go stronger. And then the drugs provide a direct shortcut to that reward center, more than what natural dopamine releases do. So the little chart shows that the rewarding effects over time go down. So the person liking the substance isn't nearly as big of a motivator for using it as is just the wanting or craving. So it becomes, so if you know somebody who's been using substances for a long time, they're probably not going to tell you they like it anymore. They're just going to tell you they need it. So when we're talking about the science and what that looks like for recovery, neuroplasticity in our brain allows our brain to heal. So healing the brain and undoing some of the damage is possible, not completely, but we can see that person return back to previous functioning and personality over time. So the substance use creates deep, strong pathways in the brain, which become more dominant with frequent and consistent use. So when we were talking about adolescent risk factors and the developing brain back then, we talked about before age 10, it's really about making the connections and increasing the density of the brain. Every action we take, everything we learn, every behavior we practice creates pathways in our brain. And so before age 10, we just want an abundance of pathways. And then after 10 or around 11 or 12, we start pruning those pathways. So substances do the same thing. They create those deep, strong pathways in the brain. And with more dominant, frequent, and consistent use, those pathways become stronger and stronger. The brain can be retrained over time, but it requires as much attention and intention to build those new pathways. So just because we have a new pathway does not mean our brain's going to use it. We have to make that the dominant pathway by frequent and consistent use. So relapse. The pleasure centers of the brain are hijacked by addiction. This is a biochemical process and not just lack of control or lack of willingness. It is biochemical that is part of the habit. And then the old neural pathways of substance use can weaken, but they will never go away. So once the brain remembers that pathway is there, it's going to want to use it again. So recovery, the brain is designed to heal and grow through relationships with others. We are social beings, and when we have positive relationships with others, recovery is that much easier. So when maintaining a healthy, positive relationship with the person we're trying to support is by far one of our biggest roles. The brain wants all of its disparate parts to work together. So what that means is we can't, when we talk about we just can't treat substance use, we just can't treat the pathways of addiction. We also have to foster and protect the part of the brain that wants to feel productive and important in our job or our career, wants to feel connected to our family and friends, wants to feel connected to a higher power. All the parts of the brain, when they can all work together and when we can foster and embrace all parts of that, the recovery from the substance is that much more nourished. So whole health support is the key to success in recovery. So the whole health approach to treatment, we need brief intervention. We need that early intervention, that early assessment, the brief assessment, and then quick intervention to help that person when they are saying, I have a problem and I need some support. It needs to be, let's give you some intense support right away, and then we'll build what the long-term support looks like. If we wait for the whole treatment picture to be in place, we're probably going to miss our window of opportunity. Pharmacology is a big important piece to this. So we are getting more and more medications that we can use to really support this. So when we're talking about this being a biochemical issue and not just a behavioral issue, and when we're talking about the damage it can do to the brain, pharmacology really becomes an important piece of this. For a long time, we've only had medications that either deter from drug use or are needed to be taken daily. So we've had a lot of oral medication, and then we have Suboxone and Subutex, which is also oral, but not in the form of a pill. Those are only as effective as the patient is committed to using them. If they know they're going to be with a certain friend group and they might want to use, they might not take their medication that day. If they feel like they have a good handle on this and they don't need the medication anymore and they don't want to be dependent on it, they're not going to continue taking their medication. And a lot of times we see, whether it's mental health or substance use, people aren't always attributing their success to the effects of the medication. So you take away the medication and the success tends to decline as well. What we've seen in the last few years is an increase in what they call long-acting injectable medication. So the big sell on this and the big success we can see with it is that it's a roughly once a month injection, anywhere from 21 days to 28 days. The way it works with the brain is that it hinders those cravings, and it's not something that a person can decide one day not to do anymore. They can if it's their scheduled injection, but they don't have to make that conscious decision every single day to take that medication. It's in their system. They are given several weeks to see the benefits from it and focus on the other parts of their recovery without struggling so much fighting that craving, that inherent drive that their brain has now to use. Case management is a huge part of full health approach because, like we talked about, this isn't just a substance use issue. There are so many other components that go into somebody's reason for using. And when we have appropriate case management, we have resources to address all of that. A formal treatment system. So this is a little bit of what I talked about with the brief intervention. We need to get in and get that person help, but we also need to have a long-term formal treatment plan. So attending an inpatient stay for 30 days is not the end of it. Attending an intensive outpatient program for 2 to 3 months is not the end of it. We need to have a formal treatment system in place for this person. Self-help groups or the social support groups are incredibly important to recovery, not just on their own, but part of the whole treatment plan because they have that peer support. They feel that connectedness. They feel that mutual understanding and acceptance. Education. I'm such a strong advocate for whatever the issue is. The more you understand of what's happening with yourself and how you got to where you are, the more you are able to effectively manage any of the symptoms or side effects of that. Inpatient stabilizations and detox are incredibly important too when we're talking about the damage done to the brain when using and the inability to make appropriate and effective decisions. Detox helps us to physically recover from active use, and inpatient stabilizations then help us to give us at least a few weeks of time to allow our brains to heal enough that we can start thinking a little bit more rationally. And then physical and nutritional health. The whole health approach goes into when our bodies are nutritionally deficient or not physically active enough, our brains start craving unhealthy things. They go to that quick fix instead of the appropriate fix, which is also why we go to substance use in times of trauma or crisis. We want the quick fix instead of the appropriate one. So this is just a little bit of information about some of those formal treatment systems. We have detoxification, which is a medical treatment for physical dependence. So this is when you're pulling away from a substance use, it can affect your heart, it can affect your blood pressure, it can affect breathing, it can affect a lot of different things. So medical oversight is incredibly important depending on the substance. Substance use residential or a partial hospitalization program. This is where you're pulling the patient out of their everyday life and providing them a protected environment where they can heal and grow and increase their understanding and education of what they're experiencing. The intensive outpatient program is a step down from residential or partial hospitalization. And this is a little bit longer term support. It allows them to integrate back into their daily life while also having some accountability and support. So it's usually 3 days a week, coming in for several hours a day and receiving that intention and focus on recovery. So step down options after that can be individual therapy. A lot of places have aftercare programs. So instead of 3 times a week, you come in once a week for maybe 1 hour a day, and then integrating in those peer support groups. And then, of course, long-term medication support. So it's not something that person constantly has to fight on their own. If they have that medication support, it's like giving them a crutch when they broke their leg. It allows them to get around it and be a little bit more mobile and function normal instead of just asking them to do it completely on their own drive. So when we're talking about treatment approaches and we're talking about the behavioral health side of it, or how do you work with someone and get them to see that they need this help, motivational interviewing tends to be the modality that is the most effective. So motivational interviewing is really taking the approach of, I'm here to understand. I'm going to ask them questions or engage in conversations just so I can understand where you're going through. I'm not going to get into lecturing. I'm not going to get into arguing. I just purely want to understand. So when we take a motivational interviewing approach, we can pose questions or topics that help the patient realize the need for change. By helping the individual learn to accept that their feelings are valid and learn how to positively impact and modify them, someone can gain insight and the motivation needed to decrease their riskier self-harming behaviors. Empathetic and supportive yet directive counseling is the conditions needed for a change to occur. When we get into direct argument or too aggressive with our confrontation, we will increase our patient's defensiveness and reduce their likelihood for behavior change. So self-help and peer support, part of the treatment model. So these are your typical 12-step programs. So things like Alcoholics Anonymous or Narcotics Anonymous, Celebrate Recovery are some of the faith-based ones. Non-faith-based one would be Smart Recovery. And then family members also. So as important as it is for the patient to receive treatment, this does a lot of, it has a significant impact on those who are caring for them. And when we talk about trying to be supportive and take our emotions out of it and not take their behaviors personally, and needing to maintain healthy and strong boundaries, that's not something easily done in an isolated bubble as well. So family members need support as well. So the best recipe for sustained recovery is a combination of the professional treatment and then the self-help and peer support. So community supports we have here in St. Louis. So SSM, we have several different options that help people with substance use. We have our substance use IOP program where we're running morning and evening groups. Our behavioral health urgent care works with children, adolescents, and adults. It's a pretty unique feature here in St. Louis. It works just like a medical urgent care, but it's for behavioral health needs. So if someone's saying, I need help and I need help now, whether it's with my psychiatric medication or my substance use issues, we now have an urgent care that's walk-in. I think the hours are 9 a.m. to 7 p.m. And it's open 7 days a week. So they can go in and get assessed by medical professionals. They get the case management and they get connected with resources right away. And then we also have 2 of the long-acting injectable clinics. We have one at DePaul and one at Wentzville that can provide help with substance use, withdrawal, and cravings. Preferred Family Health has quite a few options: alternative behavioral care, Bridgeway, and then Centerpoint. All of those have options for both adults and adolescents. So that takes me to the end of the presentation. References, I'll leave that up there. Here's a lot of places where I got our information. But that's what I had prepared.
Lisa, thank you so much for that presentation. That was excellent information. And I would like to encourage our audience, those who may be watching on replay, to please share this video with others in our community or beyond who might find this information to be helpful. Lisa did talk about many of the services that we offer both in and outside of St. Charles County to help these folks who are suffering from substance use. And like she said, this is a very complex illness, and it takes a comprehensive approach, a whole health approach. And we're very fortunate in St. Charles County to have many of those resources at our disposal. So please reach out if you're in need of services. Be an advocate for those in your life or involved in your organization who are suffering. The need is glaring, and it's becoming made worse by the pandemic. So we are very fortunate to work in the healthcare industry to where we can offer services that truly make an impact. So I'd like to thank Lisa again for her time and for all of her colleagues who are in the trenches working with this difficult patient population. And hopefully we can turn the corner, get some people some help, and just become a more healthy community as a whole. So thank you guys so much. Appreciate it.
Thank you.
Lisa, can you please provide your contact information?
Absolutely. So my direct phone number is 636-327-1332. And then my email is lisa.wenger, WENGER, and then the number 1 at ssmhealth.com.
All right. Thank you guys again so much. Really appreciate your time.
Thank you.
Have a great week. Thank you for joining us, Karina.